Thank you so much, everyone, for joining today's session. We appreciate your presence today. It's so great to have you. We are hoping to have a good session today. Thank you so much for the past session that you've attended. These 3 months we were attending, or we are dealing with communication in palliative care. We have dealt with how to hold a family meeting and look at the principles of communication. So today we are looking at how we can then break the bad news. So we will be looking at that, and we are having Mrs. Macy who will take us through how we can break medical bad news to our clients. And then we also have a case presentation from Babane Government Hospital, Palliative Care Unit, Sister Felicity. She has just promised to join us very soon. She has been attending to a client, but we are hoping by the time we are done with the didactic session, she will be already logged in. We are hoping for you to enjoy the session. During the session, may we request that if you have the cell phone next to you, you try to switch it off or put it on a mute so that it may not ring and disturb others. And then if you have others joining with you with the same gadget, may we request that you write or introduce your name on chat. You write your name and where you are joining from and your job description or what your position you are doing in that area. So with me here I have Sibongile, who is our senior nurse, and Messi, our social worker, and I. And then we will introduce one another. I hope we have a few minutes. You just say your name, and then you say what you are doing and where you are joining from. And then we will continue. Then after you have registered or you have verbally introduced yourself, kindly then introduce yourself by writing your name on chat box there so that we can also have your details on that side. So may I start with Bongan Jele. Bongan Jele, may you unmute and introduce yourself. Bongan Jele. Okay, Bongan Jele is not getting us. May I request Bongegile Ngambule to introduce yourself? Hi, Bongegile, do you hear me? I don't know if Bongegile, you get me. Okay. May I request Nompumele Sachago to introduce yourself?
My name is Nomumete Sajwago. I'm from Satikulu Government Hospital. I am palliative care nurse. Thank you.
Thank you. May I request Nana Shandu to introduce yourself? We can't hear you, Nana. We can't hear you, Nana. Okay, Nana, you didn't join with your audio. May I request that you join with an audio too? I think that's the reason you're not getting you. May you enable your gadget to also connect with the audio. If you have used the laptop, it mustn't have the headset sign at the bottom left for you to be able to communicate with us. Okay, while Nana is helping herself, also I see Tandazile. May you join with an audio too, Tandazile, so we may be able to communicate with you too. Your gadget must not have a headset side, but it must have the microphone side. So may we kindly Okay, may I request Dr. Spade to introduce yourself?
Hello, everyone. Dr. Sipesihle, Manzini Government Hospital, SMO. I will actually introduce Nana and Tandazile. They're actually part of my team. Nana is actually our in-service nurse, and Tandazile is our palliative care nurse at Manzini Government NCD Hospital. Thank you.
Request Nompumelelo Dlamini to introduce yourself. Nompumelelo Dlamini.
Afternoon, everyone. My name is Nompumelelo Dlamini from Manzini Government Hospital. I'm the focal person there. Thank you.
Thank you. May we request Bongegile Ngambulo to introduce yourself?
Hello, everyone. I'm Bongegile Ngambule from Eswatini Government Hospital, inpatient nurse.
Thank you, Bongegile. May we request Bongani Jele to introduce yourself? Thank you everyone for joining today. For the sake of time, may I request that we write our names on chat. There's an example there that Alina have shared with us on how we can introduce ourselves through writing on the chat. So if you are joining with 4 people, you will introduce the 4 people, including yourself, by writing on the chat section there. It will help us to know who is who. And then for this time, may I request for Mrs. Shabangu to present the didactic session for us. Thank you.
Thank you, Mr. Mashamu. Good afternoon, colleagues. My name is Mrs. Shabangu, and I am the Eswatini Hospice and Home social worker. So today we are going to be looking at breaking bad news. Now, the objectives of this presentation is to explain what breaking bad news is and why it is important, discussing common scenarios and tasks in breaking bad news, explaining the challenges of breaking bad news, describing how not to break bad news, and demonstrating the steps in spikes using good communication skills. Now, bad news can be defined as any news that drastically or negatively alters the patient's view of his or her future. And there are certain requirements that we need to take into consideration whenever we are breaking negative news to the client. So now we look into, or at least the requirements for breaking bad news, especially on the health workers side, is to have patience and refined communication skills as you are delivering the news to the client. You need to be patient with the client because at some point the client is not ready for all of the information, or even the emotions and response of the client might not be what you are prepared to handle. So you need to be patient and you need refined communication skills to know what to say, how to say it, and when to say it. Also, breaking bad news must be approached with empathy for all parties. Now, empathy is expressed from the very beginning of the session with the client till the very end of the session. There's no specific part or moment of actually showing empathy. But as you start with the client, probably at the state of diagnosis, you express empathy there until you reach the very end of the stage. And then also when we break the news, it must be presented on the assessed level of the patient's understanding. So what you got about the patient's understanding informs how you are going to break the bad news, how much information you are going to give, and how you are going to deliver actually the information. It must also be based on the client's compliance during that session, and also the wishes for disclosure, because we understand that the client has the right to know information or not to know information about that diagnosis or results or prognosis. It is important to break bad news because it improves the patient's compliance and adherence to any care plans that you're going to develop with the patient. It is also important because it improves the client's emotional health. The client is able to understand what is going on with them, and they're able to actually express all their emotions and their concerns. In that way, the client is also able to start preparing for things that might follow because the client has all the information regarding their health. It also improves the informed decision-making and sense of control for the client because the client has all the information, as I've mentioned. It improves the physiological measures and pain control and the satisfaction, which from the client side about the perception of the clinician's competency. Now, on the side of the clinicians, it improves the clinician's ability to formulate more accurate care and treatment plans because they are on the same page with the client. And it also helps the clinician to have less work-related stress and reduced burnout. Because when you understand, when you and the client understand what is actually going on and what is possibly going to follow, the stress levels become reduced because there's nothing that you're withholding from the client, but you're expressing everything as is, and it also reduces burnout. So there are common scenarios where we break bad news, and these include giving diagnosis to the client. This is also when we communicate prognosis of the illness, where we explain complex medical information, where we clarify goals with the client, and at the point of determining advanced care directives. And also when we get to the point where we need to talk about dying, loss, and grief with the client, and at the point of pronouncing death. So these are the scenarios where we are able to break bad news. So there's usually difficulty when it comes to breaking bad news. And some of the reasons for that difficulty is that the healthcare worker or the clinician may feel incompetent in terms of communication. You might feel like you are not well versed or you don't have all the skills to be able to communicate with the client. There's also the fear of being blamed and failing the patient by not curing them, because we have an understanding that when patients go to the hospital, they are hopeful and they expect to actually get the help that they need and be cured. So the moment you tell this patient that with the diagnosis that we have, or with the disease that we've discovered, it is difficult to cure this illness. Now the patient might blame the practitioner, or you yourself as a healthcare worker can feel like you've failed this person because you're probably their last and only hope. Another challenge is that the feeling of being embarrassed and also not having enough time, because we understand that as we are working in the health setting or institutions, there's usually a lot of clients coming in. So you need to set enough time to see the clients. So that's one of the challenges as well. And then there's feeling powerless to handle emotional distress. I think I've mentioned this before, that you might be concerned that what happens if the client starts crying, or if the client would collapse, or the client would be angry and have outbursts. So those are some of the challenges that actually we encounter when breaking bad news. Now we are going to look at how not to break bad news. So I'm going to use a couple of examples on how not to break bad news. So there's usually the talking jargon and statistics, where the client might ask the doctor, how long have I got to live, doctor? And then the doctor's response, when the doctor is using jargon and statistics, could be, well, there's a 67% chance or 5-year survival rate amongst patients like you with the stage 1 disease. So here, from this example, we can see that this doctor used jargon and statistics, of which we are not even sure of the client's education and level. And the statistics don't really help the client when it comes to receiving bad news. There's also another example is the please don't tell scenario, where the relatives, you find that they ask the doctor or the nurse not to disclose to the client what their diagnosis is. So this is one thing that we should apologies, colleagues, for that disturbance. It seems like we have issues with our internet, so please bear with us. I hope that everyone can hear me. If you can't hear us, please indicate in the chat box so that we can correct that issue. But I'm going to continue with, because we're still looking at how not to break bad news. We had discussed the talking jargon and statistics that we said we are supposed to avoid at all costs. And then now we're looking at the please don't tell scenario, where I said that we are not encouraged to take advice from family members or relatives, that we shouldn't tell the client what their diagnosis is. So in cases like those, in palliative care, we usually say the client is at the center of the care. The client is the one that says what they want. The client expresses everything, and we respect the client autonomy. So the moment the relatives say, please don't tell the client, it means that someone else will be making decisions on behalf of the client, which is not ethical. In cases where the client is totally fine and is able to make decisions with regards to that. We are also going to look at the hit and run approach. So an example there could be the doctor telling the client that the MRI scan shows that the tumor has spread to the lungs. We will refer you to hospice and they will look after you. So basically the doctor has told the client what is going on, but the doctor is quick to refer the client to other health care providers or services. In this case, it looks like the doctor is running away from this issue. And if the doctor is running away from this issue to the client, it says that this is a very huge and difficult thing to deal with. It's even scaring the doctor. So it is not helpful even in terms of the treatment and care plans that are going to be made in the future, because the client will have lost all hope and thinking that to the next service. Then there's the velvet covered hand grenade approach. So I'll just go through what the doctor and the client conversation. So the doctor is saying there's a bit of a lesion on the x-ray. The client asks, what does that mean? And then the doctor continues, oh, it will be all right. I'll keep an eye on you from time to time, so we won't be abandoning you. Now the patient is asking, will it be okay to go on holiday over Christmas? The doctor responds, it will be best to stay nearer home, just in case. So in situations like this, you are not really telling the client what is going on, but at the same time, the decisions that you are making or the recommendations that you are making to the client are actually showing that there's actually a bigger problem than what you are telling the client. So these examples that I've just given above are showing things that we should really avoid when breaking bad news. There's also some major no-nos when breaking bad news. Usually these are statements that we say to our clients or our patients with the hope of sympathizing with them or showing them that we understand what they are going through, or trying to lessen the burden that such news come with. So these are the statements that we should avoid. Statements like, there are many others with the same problem as you. A statement like this actually limits the client from even expressing their emotions or anything or their wishes, because you are telling them that, well, this is not a new issue. Others are going through the same thing. In as much as that can be true, but the patient, when we focus on a patient, we're not looking at them as a group, but we're looking at the one that is in front of us right now. So generalizing is not helpful. Another statement is, there are others worse off than you. This statement is very hurtful even when said to anyone, because you are basically telling the patient that their concerns and their emotions are not valid. But there are other people who could actually be worried or more concerned than this patient. The way that we experience things and the way that we react to things, we are able to see how heavy does this thing weigh on you as an individual. So we are not encouraged to be comparing patients. This statement would rather be used by the client or the patient to say, I can hear you, but I think there are others who are worse off than me. It is best coming from the patient than from you as a health worker. There's also the statement, be positive and look on the bright side. It's also a statement that is not helpful, or we all have to die someday, or don't worry, it's going to be okay. There's also this one where you say, if you stop X and Y habits, start eating healthy and taking your medicine, you will be fine. Sometimes the statement is true, but sometimes it is not. So we really should be considerate when we try to give empathetic responses to our clients. So now we are going to look at the SPIKES protocol for breaking bad news, where we have 6 steps, which is when we look at the setting, the perception, the invitation, knowledge, emotion, and summarizing. So we are going to go through each stage. So the first step is the setting step, where we are actually getting started. So now we are breaking bad news to the client. So in the setting step, we pay attention to the physical space where we are going to hold the session with the client. So in this physical space, we make sure that we get the setting right. So we consider the environment to be actually a warm one. We can create a warm and welcoming space, and making sure that it is a very private space so that the client can be comfortable throughout the session. And you also prepare what you're going to say to the client prior. So you're going to go through their medical notes in order to be sure that you are sharing the right information to the right client. You are not missing out files, and you understand where the client currently is at that point. So you prepare prior what you're going to say during the conversation. So now this will promote a successful and optimal communication. This is where you'll also get a chance to prepare for an appropriate vocabulary to use and where you review the information to be shared, like I said before. Now, this helps you to be more prepared and less anxious. Also, still on the setting, if you're working in close collaboration with another health worker or physician, you try to review the news together and the implication of the news and the specific care plan together, which is very important. So now this gives and sends a strong, unified and consistent message to the client, so that it doesn't matter what the client is saying, the nurse today and the doctor tomorrow, but the client will be receiving the exact same message from the healthcare team. And then for this kind of meeting, you ensure that the significant others are involved if the patient wants them to be there for support. So you check with the patient who can join us in this meeting, and then the patient consents to those individuals, and you are able to get or together those significant others as per the patient's request. Now, we should also note that it is not necessary to rush into the news, but we should take a moment to connect and build a rapport with the client, because such news changes your patient's life. So it is important to take time to show empathy and emotional connection. When you're not rushing into anything, this opens the chance for the client to feel comfortable and so that you actually have dedicated all your time for them. There's no one that would share anything with someone who's actually rushing to get over with the process. Then in a busy facility, you find that sometimes privacy may be less than optimal. So you should try and get a secluded place, which is quiet, warm, and comfortable, and ensure that you inform your colleague that you're going to be using this room for such a period of time so that there are no distractions. And also on your side, you could silence your phone or pages or any other thing that could cause distractions. So after making sure that you've gotten the setting right, you move to the second step, which is the perceptions. So with the perception step, this is where you find out how much the patient knows. Here we are looking at the patient's current level of knowledge about their medical issue and what they think about their status on the road to recovery. So it is important to do more listening than talking at this stage. So this is where the client is talking more and you're doing more of the listening. Here you assess the perception, and the only way that you can achieve that is by asking the patient open-ended questions to find out how much he or she perceives the medical situation. So the patient's perceptions of the news will determine how much news should be conveyed to the patient. Now, as we're using open-ended questions, we avoid questions like why, because they often come off as loaded or threatening to the patient. But you can ask the patient probably what the doctors have told him or her, so that the patient can tell you their understanding, what they have heard from the doctor about the disease. You can also ask the patient if he or she has been worried about the presenting symptoms. And such questions actually enable the client to expand and go deeper. And explaining that it would be helpful for you as a practitioner to know what they understand about their illness also makes them comfortable as they express their views. So at this point, there is no need to challenge the patient on inaccurate or hopeful beliefs, because in this stage or in this step, the client is actually expressing what they heard and what they think is happening. So don't challenge anything that they're saying, even if it is the complete opposite of what is currently happening. But instead of challenging that, as you continue engaging with the client, you can correct any misunderstandings that he or she has. And you can also tailor the news according to the client's understanding and expectations. So it basically guides you on how you can tell the client and what you can actually say to the client. It is also important to be mindful of the client or the patient's denial behaviors, because they usually have their own management strategies when it comes to dealing with overwhelming loss. So the breaking of bad news should not shatter this important coping mechanisms that the client or the family members use. Then the next step is after getting the information from the client, now it's the invitation step where we find out how much the client or the patient wants to know. So here the real issue is not do you want to know, but the issue is at what level do you want to know what is going on. Using what the patient has shared about their understanding of the illness and in the context in which the testing has been done, the practitioner can ask the permission to share the current information, the details of the condition or the treatment that they might face. So here it is key to find out how much detailed information the patient wants regarding to their diagnosis and prognosis. And after finding out how much information the client wants, then you meet them where they are. And if they are not ready for the details as we've mentioned earlier, it is not necessary to force them to listen. So here, this calls for you to respect the level of information desired by the client, but also have the family and the client know enough so that they are able to provide informed consent for further testing and treatment. So here, don't forget to wait for permission from your patient before proceeding with the news. The fourth step, which is knowledge. Here, this is where now you start sharing the information with the client. So here, as you share the information with the client, you communicate in ways that help the patient process the information. Again, it is important to ask the patient how much they understand and need them daily. So the first step in actually delivering the news is to use what is called a fire warning short, where you warn the patient and the family that the incoming news is not good. This is where we can begin a discussion with phrases such as, unfortunately, I have some bad news to tell you, or I am sorry to tell you that, or things are not going in the direction that we had hoped for. So now these statements allow the patient and the family to emotionally brace themselves for the information that is going to follow. The patient will often need you to speak in plain terms. So this is where we avoid medical jargon and statistics, as we had made that example earlier. So here we just consider the individual in front of us and have their and ask them if they've understood what we're actually saying. After whatever information you're sharing, you ensure that have you understood what I've said. So just to make an example, instead of using words like mastitized, we could use probably terms like spread because it has the very same interpretation or meaning. So we do not rush this part, but we share the information in small amounts where we can use short sentences and periodically check for understanding. So what you do here, you don't make the session a lecture where you just give the client all of the information, but you always pause to check if you are still on the same page, if they are still following you, and if they are still understanding you clearly. And then you proceed at the patient's pace, and you use diagrams or written messages. We are encouraged to have such so that they can have a better understanding of what we are talking about. And then as a health worker, you should know when to stop. When you're talking to your client, you are watching for nonverbal cues. You are seeing how they are actually reacting to the news. So you should know when to stop based on those nonverbal cues. And these conversations and choice of words on the part of the clinician can be vital as the patient and family dealing with the news in upcoming days and weeks. The fifth step is empathy, where now we start responding to the patient's feelings. So we understand that the sharing of bad news can be emotional for both the doctor and the patient. So here we create a space for the client to express their emotions, and then we practice deep empathy. We also identify the patient's primary emotion and express that we recognize that what the patient is feeling is as a result of the received information. We address the patient's emotions with empathetic responses. And the patient, you might even find that the patient will have a wide range of emotional reactions as they respond to the bad news delivered to them. So emotional responses may range from silence to dramatic crying or sobbing from the client. And this usually creates a potentially awkward situation. But this awkwardness can be diminished through engaging in empathetic communication with the client. Now, we should remember to stay calm and allow the patient time to think, and we use silence. In as much as empathy is more emphasized at the state or at the step, but we are encouraged to use empathy from the very beginning of the process. And then the very last step is strategy planning and following through. So as we've mentioned, that the patient may at the stage be feeling overwhelmed, bewildered, or disorganized and without hope. Before we discuss a treatment plan, it is important to ask the patient if they are ready for such a discussion. And if the patient is ready, we can enumerate the problems that we've discussed in a list and make a plan. And then we start explaining it and giving patient options where appropriate. We can also give preparatory information, which is important in order to decrease distress regardless of the illness stage. And one of the best ways to prepare a patient for participation in treatment decisions is to ensure that he or she understands the information that has been provided. Then you can summarize your thoughts and your understanding of the patient's reactions and set up expectations for the next appointments. Then you can end the meeting with on an intentional note by explaining what will come next. Then you provide a clear strategy, which will help lessen the patient's anxiety and uncertainty. You can also explain how you'll be available in terms of further explanations or answering certain questions. You can be available to meet other relatives that the client may consent to, and you'll also be available for support. This is the end of my presentation. Thank you.
Thank you so much, Mercy, for such a wonderful presentation on how we can break the bad news. To me, it means that if we are not going to do well the breaking of bad news, it means we will hurt more for our patient. But if we are going to do it very well and breaking the bad news right from diagnosis, we are going to be able to take care of our patients. I don't know if anyone has something to add or a question to ask. You are free to raise your hand, and then I recognize you, then you speak, or you can put it on chat. Anyone with a question or a comment to add? In the absence of any comment or question on what Messi has shared, I would say that some of the things being mentioned today have been addressed in our previous sessions. So, like the core components of communication, the things that we need to get and have before we start a communication, they've been discussed in the past sessions. And then also we have also discussed issues of family meeting in our past sessions. So I will recommend that if ever you need to understand the skills that you may need to conduct or break the bad news, such information is available in our YouTube channel. So you will like it. But as we continue with the session today, if you have something to add on what Ms. have shared, kindly share it on chat box. Or if time to share questions, I will request you to share the question with us or the comment. But for this time around, may we have a case presentation from Sister Felicity. I think you are ready, Clark. Are you
Yes,
ready?
I'm ready, Tim.
Okay.
Yes, can you hear me?
We can hear you.
Hello?
We can hear you, sister.
Okay.
Yes. I share this.
Hi, afternoon, Tim.
Can I share the screen for you?
Yes, for them, but I do have in my front.
Okay. Sister. Thank you.
Yes.
You can go ahead, sister.
Afternoon, Tim. Thank you for this such an opportunity, and apologies for delays. We're always on the run on the health sector. My name is Felicity Lukele, working at Mbabane Government Hospital in the palliative care unit. Case presentation for today is about a female patient, age 53 years old, with diagnosis of advanced cancer, cervical cancer with urosepsis. Then what is the main problem or concern about this patient? The information was, the main problem was the patient has reached end of stage. She is on palliative dialysis, and during the dialysis sessions, she crashes. Now the patient is shouting all the time and is restless due to pain and or brain metastasis. Concern is to reduce suffering of the patient, at the same time preventing toxicity, as palliative dialysis is suspended in the last 24 hours. The body is unable to excrete and also to do the preparedness of the family for disease outcome of which is possible death. Chief complaint, chronically ill-looking patient with history of chills and rigors during hemodialysis session since the 30th of May 2022. The patient also has pedal edema, complaints of back and neck pain. Patient has been shouting 24/7. She's got a confusion and there's no corneal reflex. She also has paralysis of lower limbs. She's bedridden for the last 4 days. Another problem is the healthcare workers not willing to relieve pain. They neglect the patients, cry, and not explaining the situation to the caregiver or the family. The significant medical history or surgical history of the patient. The medical history is patient is on ART, I think since 2018, it's been omitted. And she was diagnosed with cervical cancer stage 4B in 2021. She received 2 chemo cycles, and the last session was in October 2021. As she then developed renal failure and on and off anemia. She's also a hypertensive case on treatment. Surgical history, examination under anesthesia was done to rule out rectovaginal fistula on the 9th of June. And the findings were non-abnormal thing was detected, which is the NAD. Medication, relevant past medication was clozacillin, 1 gram IV BD for 2 weeks, cefapine, 1 gram IV BD for 2 weeks, vancomycin, 500 milligrams in 100 mils of normal saline weekly, and then the folic and the ferrous for a week. The current medication is I'm sorry, I wrote the Adalat, but for now it was suspended. It's the Lasix 120 20 milligrams POBD for a week, and morphine 15 milligrams IM stat, then 10 milligrams 8 hourly for 7 days. And also then the Dalcolex 5 milligrams PO at night. Okay. The social history and pertinent family history, work status, she's unemployed, occupation, which is not applicable, education was high school, socioeconomic class is middle class, marital single, lifestyle, she's neither smoking nor alcohol. Relevant health condition in their close family members, her mother had diabetes and hypertension, and she passed on. Advanced directives, the DNR, nothing written, no will written, no advance decision to reduce treatment, nothing written. Healthcare proxy, yes. It was her sister. Mental capacity assessed, yes. Comments on the mental capacity was that patient was unable to communicate as she kept shouting and not responding to verbal commands. She had a reduced level of consciousness. Upon admission, it was the GCS was 13/15. Then by the time we were doing the assessment, the GCS level was 4/15. Review of system. Temperature was 36.1 degrees Celsius. BP was 119/70. Pulse was 79 beats per minute. Respirations were 20 beats per minute. Saturations were 98%, and she's on room air, not an oxygen. Pain score, yes, it was assessed and it was 10/10. The ECOG functioning level, it was 4, as she was bed confined. A ranking of the symptoms, pain was 4. Okay, the 4 is the overwhelming, was 4. Dizziness was 2. Anxiety it was 2. Agitation was 3. Depression was 2. Drowsiness and fatigue was 1. Nausea and vomiting, no. Anorexia, yes, it has 3. Constipation, there was no constipation. Dry mouth, yes, it was dry. Although I found it lubricated, they say it was dry. Morbidity was poor. The rating was at 4. Focused investigations, it was done, the chemistry investigations were done, but I just picked one where there was the anomaly, the white blood cell count, the WBC. The results was 14.92. The normal or the reference range is either 3.60 to 9.60. And the comments was that the white blood cells were very high. X-rays, it said it was taken, but the doctors didn't document or write down the findings of the X-rays, and so I couldn't guess. The further plan, it was it's the symptom management. Advocate for pain reliever. Morphine, for morphine, it was prescribed today. Sorry, I mean like yesterday was we advocated for the morphine since the day before, but it was finally prescribed yesterday. It was prescribed after the palliative team had advocated, and the supporter, meaning the one who looks after the patient, was educated about the morphine use, and the supervisor was asked to direct the staff to continue nursing the patient. End of life stroke breaking the sad news. We conducted a session with the carer, meaning the one who looks after the patient, in the palliative care office for privacy. So we introduced ourselves and explained the role played by palliative care to terminally ill patients. So the first session we conducted was with the daughter. Okay, so we allowed the daughter to state what they know about the disease progress. And then before she just started to talk, she just cried and cried. We allowed her to cry and offered her the tissue to wipe herself. Then an additional information was given to her where there was a gap, and she was quick to ask as if this was happening to her mom. It was explained to her about the stage of the disease and the withholding of treatment, like the hypertension treatment, it was withheld, and the dialysis, it was withheld in the last 24 hours. And then she then cried again, and also spiritual care was advanced, as she stated that her mother spoke few words holding Jesus' hand yesterday, and that was her last words. Then we also looked what other she could need. She needed some sanitary towels, so we gave them the sanitary towels and the diapers, the altered disposables. Then we also, at the same time, okay, our plan was to also conduct a family conference, since we just spoke only to the daughter alone. Okay, they came in the afternoon, so it was the sister and a cousin. So we then hold another session, which we included the sister, the cousin, and the daughter, and spiritual, and we also encourage the spiritual care and readiness for death and the process of death, the process of medical reports, should they decide to sign the RST, because when they came, they're feeling that, yeah, let's take her home, just sign the RST. Then we had to give them information about those taking such decisions, so that they have an informed decision where they take it. Another plan is to meet as an MDT. MDT is the multidisciplinary team, all the teams involved in the care of the patient, to conduct a care conference. So the team which is in the care of the patient is the renal team and the chemotherapy team and the ward team, meaning the nurses and the assistants. Then also we plan to link the family to the hospice team. Should the patient pass on, we know our hospice team also continue to give support after death. So today we managed to meet with the renal team, so that we update each other and talk the same language with the same understanding. So with the chemo team, sometimes it's difficult to meet, but the renal team, then we were with the daughter, we explained, and today the patient is even looking brighter today. This morning she went for the chemo session, she didn't crash. Even the daughter today, she was so smiling and saying, "Mommy, we are now singing." They keep on opening a cell phone or music on the gospel channel for her. She's still alive. And today she had also gained the cornea reflex. Yeah, that's the end of my presentation.
Thank you so much, sister. I don't know what to say, but thank you so much for the wonderful case presentation. Is there any comment that we can have? Sister Felicity's presented case on what they've done, what is the patient, what is the problem, and what they've done, and what challenges they are going through as a team, and then what plans they are on, and what they are looking forward to take care of this patient. To me, this patient is already on terminal phase. And ECOG 4. So the only step now left is ECOG 5, and the only step on the other side is the end of life. So he's already at the end of life, and somehow, so they try everything, other treatment already been withdrawn and withdrawn. And what the team can say, and how can we advise sister to the Babane team to give quality care to this patient? You can ask, sister is still available, she will respond. You can add on how best they can help this patient. Thank you so much. Anyone with a suggestion or comment for Sister Felicity to take care of this patient that is already in terminal phase or end of life stage? Anyone with a question, you can write on chat box. You can unmute yourself and then you share your comment. We are ready to respond. Anyone with the input, and my team, if they have something to say. I'm aware that some of our colleagues are palliative care nurses here. Maybe they can have something to add on what Sister Felicity has already shared with us, or some comment or some question.
Sorry, just to add,
Yes.
it was quite a sad experience. It was a sad experience to see healthcare workers neglecting a patient inside the ward, and the comments they are saying doesn't sound so good. So the carer was even depressed by the treatment she was receiving and the attitude of the healthcare workers, such that I had to intervene with the supervisor, and what they said, oh, okay, we're sorry. See, so I wish people could still have low numbers of caring, even when there's no much improvement is expected from the patient.
Thank you, sister, for such a comment. Anyone to add or comment? I've seen you, Bongagile, whether you were mute or you want to say something. Bongagile Gambule, did you want to say something? Anyone who may want to say something on the management of the client, if ever you may need to see the case, I can project it again on the screen. I can see some comments coming in on chat box. Petsile is saying, thank you, sister, for presenting and the good work. And Dr. Spesile is saying, thank you, Sister Felicity and Babane Government Hospital for the presentation. We need to empower our colleagues by educating them on palliative care. And I have another comment from Lungile Masudu. Lungile is saying, thank you, Hospice, for this meeting. Really fruitful. To Sister Lokele, thank you as well as for presentation. This is very traumatic experience, but we trust for my group. We trust for I don't know whether it was like that. I'm sorry, I don't see where now it goes. Now I'm lost. I don't know where it is gone now. Wait a little bit. I'm still going through the comments. Let me do this. I want to see the comments. Yes. I was reading Lumine's post for. Okay, this is very traumatic experience, but we trust it for strength. Thank you. Those are the comments. We appreciate them. They are appreciating your work, sister, and they're appreciating the gap and the need for education. I think it calls for us to strengthen the issue of inviting them to these sessions. I think they can get more and more when they are engaged in this session. Anyone else who wants to add something? Indeed, it's a traumatic experience to have a patient shouting with confusion, sometimes with a severe pain, 10 out of 10. It's very bad. And seeing a relative crying in front of you, it's very painful. But we thank Bambara government for what you have done. Anything we think we can add for sister to do moving forward in this case, what else they can do, or do we have any question to ask? Anyone else who wants to encourage or ask or add? I understand that the patient's last words that were heard, okay. I can see you, Nana. Do you want to say something? Do you want to say something, Nana?
Yes, please. We have a question, Mr. Masham.
Okay, you can go ahead.
Yes.
Hi, Mr. Masham.
Yes, how are you?
Oh, yeah. Yes, thank you so much for the presentation, and also thank you so much for the case from Babane. Towards the end, they presented that at some point the focus was much on the daughter, the family, discussing the prognosis and probably what to expect. We didn't hear much of what they were discussing with the client. So now the question is, was it because our assessment was like, if we tell the client, it might depress the client or whatsoever. So now we are preparing the family on the side, or the approach was they discussed with the clients, then on a separate now, they decided to have a session with the family.
Thank you, Nana, for the question. I think, Sister Felicity, have you got the question?
Yeah, yes, I think so. By assessing the mental status of the patient, there's nothing you could communicate with the patient that could make sense, because she was just shouting. Her mental status was now offline. So what we did, we moved away from the patient, with the daughter to a certain place. So because of her mental status, the cancer has metastasis to the brain. So it could be the hyperemia or the metastasis. Now the patient is confused.
Okay.
Yes, I think, Nana, your team has been answered.
Yes, please. Yes, we have it.
Okay. Anyone with another suggestion or question to ask sister or to add on the management? You can unmute yourself and share your comment. Another thing that I can learn from this, this patient has cancer, and you can tell that though we are not sure when did they discover the condition, you can see that the patient's spirituality is being verbalized, but we don't know what could the patient want, as the advanced care directives are not yet done. In terms of, will the patient want to continue the treatment? Will the patient, what the patient would like to happen at this time? So, and the last words of the patient that were heard was that somebody needs to hold the hand of Jesus. So we don't know whether the patient wanted to be helped with, to be born again, or wants to say something. So we can see that if we started early, now Mbabane Government Hospital has to run to help the patient. But you see that if it was started early, maybe they will have the time to discuss the issues that were there. Now we will use our understanding to say, we are withdrawing this, we are doing this, but we don't know exactly what the patient wants, because the mental status now is not helpful that much. And now we are going to rely on the relative. It will be unfortunate there if the relative don't know exactly what healthcare decisions the patient will do at this stage. I don't know, I can see Bumi Khatako from Katikulu posting and saying, thank you, sister, for a wonderful presentation. Anyone else to say something? I'm having 3 minutes now, so we can then wrap up. To add for sister.
Just to add, but another tough thing is apparently the patient was staying in South Africa, and this daughter is staying here in Swaziland. They don't have that much bond, so yeah, that kind of end. She's dying without seeing the other children. What I encourage them is, if possible, they should come and see her and be with her before the death. So yesterday they said one is on the road from Pretoria. I think she arrived late. She'll try to be around and see. Then I avoid myself, I'll be around until tomorrow. Then I have to tell them my schedule, because they might be now looking for the continuity of the conference or the discussion. Yet then find, oh, she's not there unknowingly. So yes, you do encourage others to come and get the news from the source, and you tell them you won't be there. So that's another issue. We don't know whether the confusion, she wants to see her kids and the kids are okay. But yesterday she was saying, I want to hold your hands. Then the daughter said, okay, let me give you my hand. Then she said, no, I want to hold Jesus' hand. So that was the communication. But today she's smiling and she was listening to the music, the gospel channel.
Thank you. Nana has a question for you, sister. He's saying, hey, hi, Felicia. I want to know about the living will.
Writing a will, it's something still, most of the sources are not yet there. So, like, as I said, she was living in South Africa. There's no will, in short, there's no will. Whether she had accumulated something there in South Africa, or she doesn't have, apparently the big sister, the younger sister was saying, oh, now we'll have to take care of everything. So let us get ready for anything.
Yeah.
You
need to brace yourself for the others who come to South Africa and say things. But thank you so much, sister. I think we can learn from your case, and all of us can learn. We will extend the time to be long, but because of time, we cannot take long more than this. May I appreciate your presence. There is a feedback link that we have to share with you. May we request that in our next session, we will be on our next session will be on the 29th of June. We will be looking at, now that we have broken the bad news, because breaking the bad news is the initial step in starting the difficult journey that we work with our clients. Now that we have broken the bad news, how then do we set the goals of care with the patient. So we'll be getting those equipment that will help us to now set the goals of care. So it's a series this time. So we are starting from communication itself, and then we look at the family meeting itself. Now we are looking at breaking the bad news. So in our next session on the 29th, we'll be saying, now we have broken the bad news. Mercy talked about that at the empathy stage. One of the things that you do is now we start to avail ourselves and be ready for planning. Then the next presentation that we'll have on the 29th, or the same time, 1300 will be on the goals of care. Now, how are we going to plan the goals of care with such a patient, even including a patient like this one that we have today, that now we are already, the plan of care is end of life. Then how do we move with the family and anyone involved in a plan of care? Regardless of the palliative care phase or epoch fatality that the patient is in, we'll get those tools with how can we set up a plan of care for any patient after we've broken the bad news to move forward. Even how do we go about the issues of in reviewing the plans of care. So in palliative care, the processes are in the cycle. Now and then you are planning, now you are breaking bad news, now you are planning, now you are doing this. So it comes, it's like it's a cycle. Now you are in ethics, now you are, that's why we started with the ethics, so that you can move well to communication. So it's a cycle, one pulls another one. So you cannot predict that now we have broken the news, we will not break others. This one's case, we are breaking the bad news of that death is an enemy not to defeat it this time around, but to embrace. But comfort is something to maintain going forward. That's why now Babane government is putting all the measures to protect or to give the quality of care to the patient. And I'm happy that they even shared with the family the issue of linking them to an external source other than Babane. We are improving their quality of life. So thank you so much for attending today's session. And we encourage you to share your feedback with us. That is always appreciated. It helps us to improve and do better. Alina, I hope we have shared the link with our participants to share. Even if in the registration link, when you are coming for the second session, it will be there. We will request you to share the feedback with us. It helps us to improve. Thank you so much for attending today's session. May the good Lord bless you in all your departments as we grow. Next time, let's invite more of our team members to attend with us and to share one screen, and then we learn together. Thank you.
Thank you.
When you exit, kindly click on that link that has been shared with you. When you exit, click it, then it will help you to share a feedback with us. It's only 2 minutes, and it is very short. You will be done. Bye-bye.
Bye-bye. Thank you.
Thank you.